Good morning, everyone. Shall we start? I have a privilege to welcome you to this plenary session on health governance, policy, and institutional framework for just and sustainable health systems. As we gather researchers and policy makers from across the world, we believe that the path to equitable climate resilience, because we've been talking about climate change and health, and the high-performing health systems is shaped, and not only by the clinical interventions, but the quality, relevance, and the sustainabilities of the policies and institutional frameworks that govern them. Let me introduce myself. My name is Ayako Inagaki. I'm the Senior Director of the Human and Social Development Sector Office at the Asian Development Bank. In that role, I'm overseeing the Asian Development Bank's lending and non-lending operations in all sectors that are associated with human development, education, health, social protection, and there's no doubt for us that investing in the improvement of the health sector is our top priorities. I have spent my entire professional life in development, my early years in Africa, later on in Asia and the Pacific. I have witnessed, like many of you, how the economic and financial crisis, natural disasters, human conflict, and health crisis affect human development and exacerbate inequity. So I'm so excited about our session because it's also my belief that robustness of public policy interventions and institutional framework make a true difference in addressing crises in human development. Before we begin, just a reminder as before, please download the app of Slido and connect via the QR code if you want to be an active participant. So today, with our expert speakers, we will explore three interconnected areas that are critical to achieving just and sustainable health system. One is cross-sectoral cooperation, second is the role of market, and the third is digital transformation. And each offers both opportunities and challenges that demand our full attention. When we look at cross-sectoral cooperation, it's complex, but we also know that health systems do not operate in isolation. In the recent policy-based loan operation in the Philippines, I do remember that 30 ministries and agencies were involved in what the Philippines is undertaking on the reform on the universal health coverage. So, the social determinant of health, that education, housing, environment, create a landscape where health outcomes are shaped far beyond the clinic walls. But cross-sector reality also brings fragmentation, inefficiency, and even competition between institutional mandates. And I think many of you have also felt that sometimes this frustration that perhaps intersectoral cooperation is not moving as fast as we want. Governance frameworks that foster cross-sectoral cooperation, such as interministerial committees, shared funding models, or integrated accountability system are essential. All this is about fully aligning diverse sectors to collectively advance public health goals. The global experience shows that when we build structures to integrate policy across sectors, we can strengthen our health system and amplify impact. Unfortunately, the successful examples of this work are still too rare. The second, turning into the role of market. Markets are powerful forces in shaping health systems, sometimes for good, sometimes with unintended consequences. On the one hand, markets have driven innovation in health technologies, pharmaceuticals, and service delivery model, creating new possibilities for efficiency and quality. Public-private partnership can often fill the gaps. On the other hand, without strong regulatory oversight, the market dynamic and the powerful conflict of interest among stakeholders can distort health systems and can exacerbate inequities and prioritize profit over public goods. So striking the right balance between allowing the market forces to improve, to innovate, while regulating them to safeguard equity is our aspiration. Some mechanisms, for instance, the pricing reforms or hybrid insurance schemes, offer us valuable lessons on how markets can be steered toward supporting high quality, accessible health care for all. But we still often struggle to navigate this challenge and to invest in public institutions capable of meeting the fast-evolving regulatory needs of the health sector. Finally, we cannot ignore the digital transformation that is reshaping health systems globally. The potential of AI, big data, digital health innovations to transform everything from resource allocation to personal care is immense. Yet, these advancements come with a real risk. Without equitable access and ethical stewardship, digital health may, and is already, widening the gap between those who benefit and those who are left behind. We must ensure that these digital tools and innovations are integrated into the health system in ways that enhance equity and sustainability. This means urgent work to build robust governance framework for data security and investing in digital literacy for both the health workers and the communities. So digital health revolution can be a driver of justice and sustainability, but only if we govern it with those principles at the forefront. With that, let me introduce 4 wonderful, distinguished speakers and our panel moderators. Right. So our first speaker is Kelly. She is a Tier 1 Canada Research Chair of the Global Health Governance at Fraser University in Canada. Kelly is a distinguished researcher dedicated to addressing global health issues that transcend national borders. She was previously professor at the London School of Hygiene and Tropical Medicine, where she directed the WHO Collaborating Center of Global Change and Health and the Global Tobacco Control Research Program. She currently serves on the WHO editorial board for the Global Report on the Economic and Commercial Determinant of Health. She also leads the Pandemic and Borders Project, which investigates travel measures during the public health emergencies, and the Social Science and Humanities Consortium supporting Canada's biomanufacturing strategy. She is a fellow of the UK Faculty of Public Health, the Canadian Academy of Health Science, and the Royal Society of Canada. The second speaker is Suwit, or he told me to call him Dr. Suwit, a dedicated public health specialist and policy advocate with over 3 decades of experience spanning work from grassroots to high-level policy setting. He served in multiple roles, including as an advisor to the Ministry of Public Health in Global Health, as a board member of key Thai organizations such as the National Health Security Office, the National Nanotechnology Center, and the National Science and Technology Development Agency. He chairs the Committee for Yoti Health Innovation District Development and the Subcommittee for the Development of the National List of Essential Medicine. Suwit is the Vice Chair of both the International Health Policy Program Foundation and the Health Intervention and Technology Assessment Foundation in Thailand. Now, let me turn to our third speaker, is Daniel. Daniel is a senior researcher at the Center of the Study of State and Society, an independent researcher at the National Council of Scientific Research, and senior professor at the University of Buenos Aires. He was previously president of the International Society for Equity in Health, director of the Health Policy Department of the Center of the Implementation of Public Policies Promoting Equity and Growth, as well as the director of the Argentinian think tank, the Health Policy Department at Fundar. Since 2016, Daniel has also served with distinction on the board of Health System Global, holding various roles including executive board member, treasurer, coordinator of the Regional Expansion Committee, and chair of the Program Working Committee Group for the 2022 Symposium in Bogota. Now, our fourth speaker is Parfait. He's the Country Engagement Health Financing Manager for the Francophone region at the Financing Alliance for Health. Parfait is a public health expert with extensive experience across several critical areas, including policy development analysis, evidence-based strategic planning, and health financing functions review. For over a decade, Parfait served as a head of the Planning, Monitoring and Evaluation and Health Financing Department in Rwanda's Ministry of Health. During his tenure, he played a central role in coordinating the design and implementation of various health financing and human resources for health reform aimed at strengthening the primary healthcare system to achieve universal health coverage. Finally, our distinguished panel moderator for this session is Kalipso. Kalipso is the Director of Health Financing and Economics at WHO in Geneva. She was the founding head of the Department of Health Financing at the Global Fund and a visiting professor of global health at the School of Public Health, the Imperial College in London. So as you could see that all our speakers and moderators have extensive experience that they are eager to share with all of us. So now, without much ado, I would like to welcome our first speaker, Kelly, to the podium. Kelly, please.
Thank you, Dr. Inagaki, and to the organizers of the conference, and thank you to our Japanese hosts for making us feel so welcome. It's very much appreciated. So in my brief remarks this morning, I want to provoke some forward thinking about how we navigate some of the issues just described by our chair. The focus of this session on governance, policy, and innovation, that was a slip, and institutions, anticipating what I'm going to say, is ideal. So we're living at a time when all of these elements, which are the mechanisms by which our societies function as societies, are facing major challenges. Multiple crises are needing our attention at a time when our institutions responsible for navigating us through these crises are themselves struggling to facilitate consensus, both within and across countries. And instead, many societies become highly polarized. Many people feel disillusioned and even distrustful of governance, policy, and institutions. And this is a serious problem for all of us, including those seeking to create effective functioning health systems. So as someone who's studied global health governance for over 3 decades, I want to help us to better understand where we can go from here. If we are to successfully navigate the 3 themes of this session, we need to start with the core concept of governance. But what is governance? Not an easy topic sometimes to talk about because it can feel a bit abstract. It also means very different things to different people. From a political economy perspective, governance concerns the agreed rules and processes by which a group of people set goals and take action to achieve them. This group of people might be a country like Japan, it might be a private company like Samsung, or an international organization like WHO. When any group of people wish to set agreed goals and move forward towards them, governance sets out, for example, who holds authority and how that authority is exercised, how decisions are then made and for whose benefit, and how resources are mobilized and used. And interestingly, the origin of the word governance comes from the Latin word for pilot or helmsperson. The gubernator is the person who steers a ship through potentially troubled waters towards a safe harbor. So we can think about governance as the process whereby an organization or society steers itself, as American political scientist James Rosenau described. Who's steering that ship and where is it going? How well governance is practiced are the quality of our institutions, their adherence to what are recognized as good governance principles, their ability to serve the needs of who they govern, directly impacts the health of our societies. Well-functioning health systems, in other words, requires the well-functioning governance of societies. If governance breaks down, then we have rules and processes that people are not willing to buy into, where the social contract between those who govern and those who are governed comes under question. And this is what we are seeing around the world. As shown in this slide, there is much variation in levels of public trust in national governments. In some countries, large numbers of people who do not feel represented by their political leaders, elected or otherwise. Large numbers of people who feel existing institutions are unfair or not meeting their basic needs. Others are supporting alternative forms of authority and decision-making. And there's many reasons for this crisis. This did not happen overnight. Undoubtedly, COVID-19 stress-tested our governments and global institutions, and many are now judged as having come up short. And at the same time, the weakening of the social contract has been part of a longer process associated with the restructuring of the world economy to prioritize wealth generation and accumulation over wealth redistribution, financial stability, and planetary sustainability. Along the increased concentration of economic power in fewer hands, we see public institutions weakened in their capacity to prevent or mitigate the negative externalities that arise from these economic processes. So we're now in a world out of balance. Instead of government of the people, by the people, for the people, we have government of the people, by the powerful few, and for the investors and shareholders. At the same time, markets are still an essential part of any society. As our chair described, markets are a source of livelihoods, produce essential goods and services, and are important drivers of innovation. Markets are even an essential part of the ecosystem of health. The problem is when commercial actors and processes become so powerful that we have what is called state capture, when private industry uses its political influence to take control of the decision-making apparatus of the state, such as regulatory agencies, law enforcement entities, and legislatures, or when they cause harms to human health from what they do, what we call the commercial determinants of health. So how do we move forward towards equitable and sustainable health systems? Well, it's perhaps a bit difficult now to feel optimistic currently. I'm finding inspiration from important thinking happening on political innovation, that's as a new source of ideas and change. So in the late 2010s, political innovation began to take off, building on the successes and learnings from social innovation. Political innovation can be defined as changes in how we practice democracy and in the infrastructure that operationalizes democracy. They are innovations that ensure that democracy remains an effective and suitable operating system to achieve social order and progress. That was a quote. Political innovation is about creating new ways of distributing and exercising authority. and to agree shared goals and how to achieve them. For example, how might we better represent people than just asking them every 4 years? Or how might we enable people to contribute to decisions that directly impact their lives? How might this in turn renew the social contract and rebuild public trust? And how might this lead to better decisions that serve the many over the few? So sounds idealistic perhaps and unachievable, but actually there are many countries that are already doing this. A good example is Switzerland, which is known for its fine watches, chocolate, incredible mountains, and the headquarters of WHO. But what I think eclipses all of these things is the way Switzerland is governed. So given the limited time, I won't go into any detail, but there's 2 things I wanted to point out. First, that the Swiss parliament is composed of representatives from 12 political parties, not just 2 battling it out, but 12 political parties. And the role of national council members is actually just part-time. It's approached as a kind of community service. 60% of their time is actually doing other jobs, real jobs, I guess, and some would argue. There are no career politicians. And the second thing is that Swiss citizens take part in direct democracy by voting on referendums multiple times each year on a range of different matters, including new legislation. So it's perhaps not surprising that public trust surveys of OECD countries rank Switzerland near the top or at the top of levels of trust in government. But of course, it's not only national governments that need innovation. Our global institutions would be wise to do the same. Anyone who has sat through a World Health Assembly will know that decision-making is far from nimble. 3,500 delegates from 194 countries. Agendas are long and diverse. There's 1 week to get through it, and there are vastly unequal capacities to meaningfully participate. A few weeks ago, an African delegate said to me, "Why do we even go to the World Health Assembly? What difference does it make?" So that's disheartening to hear that. How might the WHA do things differently? What political innovations might they adopt that meaningfully engage not only its 194 member states, but people around the world in ways that rebuild public trust in WHO and the global social contract? Which takes me to the third theme of this session, digital technology and AI. Governance needs today are far more complex than they have ever been. We have these 194 countries, trans-border needs, flows, and cross-border issues arising from them, increased perspectives, and urgent collective action problems. Digital technologies may be a driver of some of these challenges, but they might also be an important source of political innovation. So for example, Christopher Rolls writes about how AI tools could empower British voters. AI might help gather and process the overabundance of data and evolving knowledge more effectively, or identify growing concerns before they become insurmountable barriers to action, or take the political temperature of citizens more frequently, or be used to counter and not just spread misinformation, or even to engage with priority populations in a timely and appropriate manner. So these possibilities are all embodied within the concept of digital democracy, whereby technologies are harnessed to strengthen political communication, political participation, and policy making. So to close, I want to encourage the global health and health systems communities to take heart. It's difficult to know how to practice good governance amid very stormy seas, but please consider engaging with the very important conversations taking place around political innovation and digital democracies as opportunities for positive institutional change. Thank you.
Thank you very much. Thank you very much, really, Kelly, to set the scene for really how to build public trust through political innovation, giving a good example of Switzerland, for instance, and emphasize the role of the potential of AI to empower citizens and what we call a digital democracy. Thank you very much. Now, let me now turn to Suwit to come to the podium and make this presentation. Thank you.
Thank you, Ayako. Morning, everyone. Can I sit here? Can I stand here instead of there?
Yes.
I feel much easier to stand on the stage rather than hidden by the podium. I'm not sure all of you is aware that last week there was a big event in Asia. The Maceira Award was given to 5 people, actually 4 people and 1 group of people. Maceira Award is to recognize the memorandum of the memory of the late President of Philippines, Maceira. It was said to be like a Nobel Prize for Asia. And the rural doctor movement in Thailand was given the award this year. They are the people who work frontline for 50 years to ensure equitable healthcare system and move for the universal health coverage of the country and be part of the governance. Not just working at the front line, but be part of the governance. The current Secretary General of the Universal Health Coverage is a former rural doctor. How can this happen? If you ask me, I would say, thanks to the US. In 1960s, when US has the Medicaid and Medicare and start the Vietnam War, they need huge number of doctors and nurses. So they drain from everywhere, including my country. What did the government do? They immediately imposed a 3 years compulsory public work for every new medical graduate, including myself. I was the 6th batch. I have to work for 3 years in the rural area. I'm not clever. I work for 8 years. Those who clever leave after 3 years. And then we learn that, the next day we graduate, we become the director of a hospital, knowing nothing about management. We were cheated, we were duped, we did mistakes. So we need self-help. We cannot wait for the ministry. So we grouped together into a rural doctor movement. What should I do with this? Okay. There, 3 of them up there, representative of more than 10,000 rural doctors now in Thailand, spread over 800 rural hospitals. Many of them are in this room, a few of them actually. And that's the path that they move together with other civil society organizations and politicians and bureaucrats towards universal health coverage. Not only financial protection, but ensure equitable health infrastructure. Okay? How can I move back? My key message to you today is that if you want a just healthcare system, inclusive healthcare system, you need participatory governance structure. You cannot let the governing structure to be based only on state, governance by state. I'm a civil servant through my life. I know how bad bureaucracy is and will be. We need participation. With participation is not enough. Those who are in the governing mechanism must be committed and competent. C plus C equal good governance. Oh, sorry. What should I do? Oh, yeah. These are the examples. If you look at the Global Fund, they have NGOs, they have private sectors, not only government. You look at our National Health Security Board, which governs $7 billion a year of universal health coverage budget. You see there are 5 NGOs, 5 providers, People ask me, how can they be there? It's conflict of interest. I said, no, we are participatory governing mechanism. And they are the ones who are very strong. Those ex-officials are usually tame. And we have 7 independent experts. Where are they from? They'll be elected by the 23 members up there. So there are lots of lobbying. That's how we get Dr. Viro, who speaks in many sessions here, on the board of the new universal health coverage. And he chaired the benefit package committee to ensure that we have good, affordable, cost-effective, new benefit to serve our people. That's why our benefit package includes from just common cold paracetamol to cancer treatment, to organ transplant, bone marrow transplant, whatever, everything, all the essential medicines, totally free of charge. We also have National Health Commission under National Health Act of Thailand. This one is for participatory public policy process based on wisdom. They convene National Health Assembly, much better than the World Health Assembly, I can guarantee you. Because they never let lawyer in the room. If you go to the Health Assembly, the lawyer interprets everything. At the end of the day, the World Health Organization is not ruled by you, it's ruled by lawyer. That's what's happening now. Lawyer is everywhere. But for National Health Assembly, no lawyer allowed. No one interprets the rules, regulation. It's the assembly themselves. If there's any disagreement on any rule, decide it right away on the spot. And we have very simple rules that need no legal expert to be there. I said this, I respect the lawyer because they may put me to jail. So you see, we have 39 members chaired by the Prime Minister. The Prime Minister chaired this National Health Commission. 13 each from political side, from academia and professional, and from NGOs, civil society organization. And this is how we build good governance, balanced governance. Although our country, the whole country is not, but at least in the health sector, we fought for it. It cannot come by being given by someone. And I can guarantee you that those people who are in the power, in the state, politicians, they want to ruin this structure all the time. We have military coup d'etat. Military government initially want to ruin all this. But the people say, no, this is mine. This is mine. And we push USC to the UNGA. And the military prime minister was invited there to deliver keynote. What can he say? What could he say? Apart from, strongly support. When he come back, he changed his mind. So you have to not only have good governance, all these are theory. How can you make it into real practice? You need committed and competent leaders that put public interest as the first priority, private interest as second. And this is the motto of the father of modern medicine and public health in Thailand, Prince Mahidol. Thank you.
Thank you.
Thank you very much, Suwit. And who never dream about having competent, committed leaders really to steer what you call a participatory governance for efficient health system. So thank you very much for the living and practical experience that Thailand went through. And let's see later on if we open the Slidos whether we have some exciting comment from the lawyers from this room. Okay, thank you very much, Suwit, again. And then now let me turn on to Daniel for his presentation. Thank you.
Hi, everyone. Well, the name of my presentation is The Complexity of Governance and Institutional Frameworks. What can we learn from Latin America? And actually, this presentation is about promoting smart regulation as a tool for governance in unequal societies. Okay, so what intersectoral collaboration looks like, I'm thinking about two dimensions, a vertical dimension and a horizontal dimension. The horizontal dimension talks about a sectoral cooperation. It's across sectors, where health is talking to or not talking to nutrition, environment, education, etc. And there we have like two different approaches. One is a more systematic approach, more strategic approach, where at every moment we see different policies working together, regardless where in which minister is working. Yeah, so you have education, environment, water and sanitation, and some examples are breakfast at school, sexual education, and high school and universities, etc. Some other horizontal sectoral cooperation happens tactically when we have a pandemic, non-systematic approaches. And there is when we see the challenge of putting together institutions that perhaps are not working together or have not been working together before. When we talk about vertical cooperation, we think about cooperation and coordination within the healthcare sector, between national, provincial, municipal levels, and even including the private sector. So my discussion points are two. First, trying to make you be in Latin America. Latin America is, societies are characterized by poor income distribution. That poor income distribution affects the shape of healthcare systems. And so what you see there is fragmentation and limited ability to provide the same rights for different groups. So every population group has different package of services that are allowed to access, and that's why we have different abilities to pay or receive financial protection from the state to cover those needs. The second thing is that the multiplicity of factors at the financial management and provisional level challenges the governance of the Ministry of Health. So here, first, the point is that the governance arrangements involve social financial protection schemes where public sectors and social insurance institutions contribute. Social insurance institutions are very traditional areas within the healthcare sector in Latin America, and are fed by payroll taxes, contributions for formal workers, and they help to provide financial protection to their families. So what you see is three cases, Costa Rica, Argentina, and Colombia. In all three cases, you have a social financial protection scheme that involves the public sector and the social security institutions. Yeah, the public sectors are generally funded by taxes, and they provide their own services in public facilities. When you see social security institutions, what you see is that the collection of funds are based in public institutions, but the management of those funds sometimes are in non-public institutions, non-for-profit institutions, like in Argentina. Union leaders are actually managing those funds, or mutuals in Uruguay. What you see in the provisional services is mainly on private providers. In cases like Colombia, the for-profit institutions are working not only at the provisional level, but also in the management of services. So what we have is that the private sector is already within social financial protection schemes, on top of what we see at the end of each one of the three cases, that is the out-of-pocket private insurance that is covering the whole of. So private actors are players in the configuration even within national social protection schemes. And the lack of protocols and impact evaluation, as well as weak regulations, impede effective stakeholder participation, sound investment, and enhancing public-private joint activities. This is, of course, different in different countries, and in some cases, monetary and non-monetary incentives are helping to align the interests of social institutions and private institutions, providers, insurers, and managers. What we see here is each Latin American and Caribbean country is one line. At the top, you see the countries where the public or social insurance funds are the most important part of the financial of the sector. Those are the blue lines. And then you go down and you get into the poorest countries of the region. The red part, the red share of each line belongs to private funding. Interesting, in countries with better regulatory frameworks, private sector funds health insurance schemes and co-payments, but in countries without strong regulatory frameworks, the private sector funds optimistic out-of-pocket services. That brings an issue that different financial setups of health systems create different governance environments, where power resources affect the role of the state in the policymaking process. And here we come with a very interesting issue that is decentralization. Decentralization, from my perspective, is seen in general as a tool for health systems reforms. And the good thing is that they promote separation of functions and accountability. But decentralization is the only tool that is also a goal itself, because it talks about distribution of power, about democratization of power. So what are the challenges of having decentralization in our countries? First, decentralization requires intensive use of something that in Latin America and the Caribbean is scarce, that is managerial capacities. Also, institutional frameworks demand alternative governance arrangements. So what we see here are two examples of two big federal countries in Latin America and South America, Brazil and Argentina. And how in those countries the funding is based at the national level, the subnational level, or the municipal level. And this is a huge difference between the two countries. In Brazil, 65% of the funding, public funding, is paid at the Ministry of Health, the Federal Ministry of Health, while in Argentina, 62% resides at the provincial level. That creates different challenges at the national government to align the interests of the populations in terms of health coverage. In Argentina, federal level controls only 20% of funds. Priority setting and implementation are at the subnational level, which requires strong coordination efforts to align subnational power and reduce cross-provincial inequities. Differently, in Brazil, federal level controls 65% of financing, and priorities and the way the mechanisms of priority setting are defined. So the management and implementation belong to the national level. The possibilities of controlling, monitoring, and aligning the interests of the population with the shape of the healthcare systems are very different. So just to end, some key remarks. First, sectoral cooperation across public authorities, nutrition, education, water and sanitation, environment requires the ability to collaborate and necessitates governance arrangements. Usually, the lack of such cooperation lines leads to the creation of new coordination bodies that crystallize the division of tasks with its proper follow-up. Fragmentation and lack of sound regulation affect the policy-making process, harming priority setting mechanisms and reducing equitable access to health. Finally, beyond financing, fragmented systems require strong regulatory capacities, sometimes defied by weak institutional frameworks. Thank you very much. Here are 3 quotes that you can look at if you want. The first 2 of them were special issues that we launched yesterday. One is about intersectoral collaboration, and the second is about health systems under stress, where we discuss what happened during the pandemic. The third link is about Latin American and Caribbean healthcare systems, if you're interested to learn more about. Thank you very much.
Well, thank you very much, Daniel, for a very comprehensive analysis of regulatory frameworks and how the actors such as public and private sectors are part of the financial protection schemes, but it really depends on the robustness of regulatory frameworks. We also learned that when these fragmentations across sectors is happening, there's a new coordination body that may be required, but also they may be subject to then, again, how strong the regulatory frameworks will come up. So it's a lot of challenge that we hear from the Latin America region. Thank you very much. So now let me turn to Parfait for his presentation. Thank you very much.
Thank you very much, moderator, and thank you so much for the invitation to us to present the experience of, talked about the experience as a policymaker. And the topic of today is quite interesting. And if you want to build just, sustainable health system, it requires cross-sectoral collaboration, and also it requires strategic partnership. And we have also to acknowledge that the private sector is no longer a gap filler. It's a strategic partner, the government. So I will try to unpack based on their experience as someone who has worked for the government. So starting with the strengthening the cross-sectoral cooperation. These are the facts that has been there. Political will, policy framework, they're all available. Pro-poor, inclusive policies aligned with international commitment, and the health in all policy framework that has been adopted by country, pushed by international organization, and we have seen that with the COVID experience, this has made somehow very now practical and pragmatic to be adopted. So this is the facts. When we talk about the role of market, private sector, collaboration, digital transformation, I'll talk about this that I think of the current facts. So there's a current narrative that's out there. Some of the policymakers that are in the room, they could quickly relate to this. They say government is inefficient, bureaucratic, and lack capacity to deliver the promises to the people that they have been delivered those promises. And market is quite smart and efficient. And why this narrative is there? It's because there is people in the government, some of the time, fear failure to engage. Why? Because they wanted to protect themselves, and that's why they outsource. They take the approach of outsourcing some of the responsibility of all the project to the private sector in the name that the private sector is efficient. And that's undermining the confidence from the public servant, even to engage sometimes with the private, because they have been just how put aside, they're inefficient, and also tackle the current challenge that they're facing. Another fact is about the unwillingness of the private sector to invest in the public good, like infrastructure, basic research, and also education. Why? It's because it's a public good that could be accessible to all, and yet they want their own things. And yet, we all know that the private sector sometimes doesn't even factor some of the external negative externality, the cost of pollution, when they are setting even the price, because they are not even equitable. I mean, the equity is lacking, meaning also fair to the other side. Another element, we have realized that the market are so powerful, sometimes aggressive, it's also unfair, especially in the area of pharmaceutical, when they put in. Some of you can also understand this. And from this, you find that the government has to step in to regulate the market. And to regulate the market, sometimes we go beyond the mandate. And when the government goes beyond the mandate, they say that government creates market distortion. Is that right? And then, by the way, the role of government shouldn't be the facilitator, but the creator of innovation and growth. Because some of the critical input, as I mentioned before, should be driven by the government. And because the government wants to create growth and also want to create value, because it has to take some of the courage to do experimentation, exploration, trial, and error sometimes, to take risks for the good of the people. Another element is the preference. When we talk about RD, because these are the things that's about the market. Sometimes it comes with this RD, and yet we know that RD is still expenditure is very low. And the preference of the government, I mean the private, more in the development part, but not in the research. Another fact that we found that the research has shown that the driver of the business to enter in particular sector is not for profit, but they look at the projected technology and market opportunities. And we have found that the government is the lead taker. In the name of innovation, we have seen taking steps, as you can see here, taking steps in terms of the project, vaccine production, use of drone to supply for blood supply, like in the case of Rwanda, you see the leadership taking the role. And also government leaders here, they committed to produce vaccine as government to drive the process. And digital health as a specific, it's been seen as a specific program, not as an enabler. So it's become sometimes, some of the countries found that it's become so like a vertical program rather than being an enabler for the service delivery. So these are the challenges, but I will focus more on the lesson learned. Some of the challenges, we are quite familiar with these challenges. There is, for the part of cross-sectoral collaboration, institution, as also mentioned before, institutions are still working in silo to address the root cause. And it's become so superficial and not addressing the root cause of the cross-sectoral collaboration. Issue of stunting, issue of climate change, issue of One Health that we are now dealing with now, and issue of sometimes social protection. RD expenditure is still low, and digital is not even reflecting the strategy. So sometimes countries even fear to take some of the service delivery model, like telemedicine, telehealth. You find they still skeptical to take this digital health in the service delivery mode. It's misinformation about the AI use, because they want to say, okay, it's going to replace your function. We are going to reduce the number of the nurses, doctors to be hired because AI is coming out. So there is a fear to embrace technology. So what have we learned throughout this process? So consistency in the leadership is very critical. You can't take these risks when there is no push, a willingness from the leadership. We need to change the language and the rhetoric. Changing the way we reason about the state, its role and structure. I've said before that we sometimes say that the government is inefficient, but yet we even don't take into account those are critical input that the government is investing, sometimes for the kids of the people, because people are for the government for the people and people for the government. The role of states is not to fix market failure. That's quite also the other narrative, but to create and shape them. But this needs to create strong institutional linkage when it comes to innovation, production, consumption, and technology. Import. We need symbiotic partnership where both parties can benefit rather than being parasitic. Sometimes we find the partnership become more parasitic. So one has to bear the cost of the other. We also need to attract right skills to also improve their wealth. Right skills, as government take the lead in taking the risk to negotiate with private this aggressive market. We need also right skills from the government people, but and make sure that they also good working condition. So I'd like to close my remarks also by saying that we need to partner with the private, but for the sake of putting forward equity, that's number one. Number two, of course, equity means that everyone should benefit because we need a fair society. And number two, we need results. That speaks what has been said before. Thank you very much for your kind attention.
Thank you very much, Parfait. I don't know how you feel about what he presented to me. It's, again, a lot of challenges ahead of us. Again, who has not dreamed about consistency in leadership, acknowledging that private sectors are strategic partners, but also hard to manage, control, aggressive market. And you need government to be a creator of innovations, right? So a lot of us as a global health community that we need to tackle on. And it's my pleasure to give that role to solve all the issues, maybe not, to Kalipso as our moderator. So thank you very much for all the four speakers and then for setting the scenes. Okay, go ahead.
Thank you. Thanks very much. So it's wonderful to be here. We'll soon be moving into the discussion part of this. But I wanted to just make an observation, a remark about the importance of positioning the global health governance conversation in the broader macro frame of global financial governance. And I think several of our speakers talked about that. And I'm saying this, and I don't think we've discussed enough, perhaps so far, the issue of debt right now in many parts of the world. So right now, 3 billion people live in countries whose governments are spending more on servicing their debt than on health or education. And by the end of this calendar year, the world's 75 poorest countries, more than half of them are in Africa, will have paid $190 billion US, about 7.5% of their GDP, on servicing their debt. And that's more than they will have spent, they will have invested in health, education, and infrastructure put together. And that is because of the way global financial governance is structured. To a large extent, it's because of the way, for instance, credit rating agencies, those private sector organizations, there's 3 of them, they control 95% of the market. They're unaccountable in that sense to the public. They opine on countries' credit worthiness, and their decisions cannot be appealed against. So they've opined that a country like Kenya, for instance, has a B- credit rating, whereas the US and France have a AA rating. And this means that the US and France, who have a debt to GDP ratio of 120%, borrow at 3%. And yet Kenya, which has a debt to GDP ratio that's half of that, that's about 65%, borrows at 18%. So that's way more than you and I can get on our credit card. And this means that Kenya this year will have spent 70% of its revenue, 70, on servicing its debt. So global health institutions, I think, and global health communities such as ours and global health professionals and practitioners ought to be able to hold to account those global financial institutions, public and private, because the latter have a very important role when it comes to people's health. And I think we should remember that. We've got the code, and I've got the questions flowing in, so let's start the discussion. Okay, so give me a minute to read this. Well, the first question I think is quite relevant to what I've just said. So it's about the IMF, the International Monetary Fund. How do you reshape or change how the IMF works to have a more fair and just health system or health systems globally? I will look at you, and as you look at me, I will assume you're interested in taking the question. So this is about global financial governance, about the IMF. Dr. Suwit praised the United States and the Vietnam War as a trigger for the rural doctors movement. So what are your thoughts about the Bretton Woods institutions, Dr. Suwit? You told us what you think about WHO.
Well, get your house fixed first. We used to spend 25% of our national budget to serve public debt back in 1985. There's no way to solve that, except you have an economic growth. If your economy has no growth, how can you pay debt? Ask yourself, if you take loans from the bank and you don't have income, and your income stays the same, how can you have enough money to send your daughter, your kids to school? So get your house fixed first. Not only that, not only public debt, we also spend 25% for defense. Get it down. Now it's at 12%. Now the public debt is about less than 10%. You see how big gap, fiscal capacity, this fiscal gap you got from just reduction of these two items. Enough for social welfare, enough for education, enough for universal health coverage. That's how we spend about 15% of our government budget on health and universal coverage nowadays. Started from 3% when we have 25% of our budget to serve public debt. Get your house fixed first, and don't listen to the World Bank, IMF. They know everything, they do everything, but most of the time they are wrong.
Thank you for that. Kelly?
Yes, I mean, the IMF and the World Bank were set up after the Second World War, and it was like they were like phoenixes in a way, rising out of disasters, right? The Second World War and the Great Depression, trying to give stability to the world economy, to help countries, when they needed, when they're hard in terms of cash flow and so on, capital flows. But many, many years later, we have to think, are these institutions fit for purpose in the 21st century, where the problems are very different? We have a system that is disadvantaging. You've just described the debt crisis. This is not by accident, this is by design. And so if we are impoverishing a huge proportion of the world's population through these institutions which prop this up, we have to think, are they fit for purpose? And so what the private sector does, which is better than the public sector, is that they innovate. Because if they don't innovate, they go out of business. But our public institutions, they seem to persist despite not innovating. And I think if we can take lessons from that and think about what do we need from our public institutions to fix this kind of global, some existential problems that we face. If our institutions cannot do that now, we need to change those institutions, and that includes the IMF.
Thank you. Thank you. Daniel, if I may come to you, given your extensive experience on Latin America, do you foresee any significant changes in the landscape in the region in the near future, or the outcomes of your presentation remain consistent, I guess, for the near future?
Politically?
Suspect so.
Yeah, I guess so. Well, Latin America now is going through a huge change in terms of the political landscape, yeah? And so we are expecting different things from, 20 years ago, the region was much more homogeneous politically, and now we see that that's not happening anymore. So I'm trying to think in terms of get your house first organized and then go global. I think that the politics today in Latin America is not helping in not only fixing your home, but looking for help in the neighborhood. So how we at the regional level can cooperate and organize some regional responses of problems that we see everywhere. Yeah. So for me, it's we are still expecting changes in different countries. In my country, in Argentina, but also with the new administration in Mexico, what is going on in Colombia, Chile. So I hope that beyond politics we can find some ground of cooperation, and health is one of the key issues that we need to address, because there are common needs, there are some solutions that you cannot find just at the local level, and you need to find regional solutions in terms of governance, in terms of regulation, beyond the international help or not that is coming from the World Bank or other regional institutions.
Thank you. Thank you. Another question that seems to be at the top of the list is about global collaboration to reduce the exploitation from private transnational health technology corporations. So how do you work together as the global community and through governance mechanisms perhaps to manage transnational, uber-national health technology corporations that seem to be emerging as extremely important players? Maybe, I don't know, Parfait, Kelly. Parfait, would you like to get us started?
Yeah, thanks so much. My view will be perhaps the collaboration happening to the regional level and also at the continental level. So as I mentioned, sometimes markets are coming very aggressive. It needs also method or mechanism to ensure that it can be regulated. So one country cannot have that kind of power to regulate that market. It needs some collaboration with other countries. So at the regional level, having one voice, and also having a way of engaging the market. So perhaps there will be some of the approach could be trying to understand, picking up some of the winners when we engage the businesses. You get some advantage to set price, to negotiate prices, but also some advantage to ensure that there is all kind of trade framework that could be across the other countries. So I think there is a need of frameworks at the regional level and also at continental level. They are there, but they need to be operationalized. So one of the things that could be we can leverage on is that those platforms or those frameworks are there, but it needs to ensure that they have the appropriate people to engage with the business, but also respond to the market needs. Of course, there is also another aspect of regulation, which also means some cross-sectoral collaboration, but also cross-country collaboration in terms of regulation. We find that one country has a strong regulation system, the other one quite very weak. It's become very difficult. if it has to, for example, if it's a commodity that has to be purchased through that mechanism, it becomes very difficult when we go to the table to negotiate, because some of them, they won't be advancing those agenda because they don't have that kind of capacity for regulation. If you put your caveat on the table, say, okay, this product or this commodity could not be purchased from our side, it's become a problem. And yet, the other person, the other country wants to.
You're talking about vaccines, maybe. Vaccines come to mind.
Vaccine or other commodities.
Or other commodities.
Thank you.
Yeah.
Daniel?
Yes, I remember that during pandemic, we have a very interesting initiative to start regional cooperation within Latin America. And I don't know if this has a follow-up. The idea in that moment was that as we are in isolation, we need some regional responses, answers to our questions. And as a country, at the country level, you were not able to solve them. So in terms of supplies, in terms of vaccines, but it went beyond in terms of access to medicines. Different countries, different power of bargaining power in front of pharmaceutical industries. Makes that the same product in one country is twice, 3 times the price you have in your neighbor country. So this idea of collaboration and bringing some kind of regional blocks and some governance ideas that then go beyond the ability of each country separately to find solutions.
Right.
So I would like to see this not just a reaction to a pandemic, but a systematic process.
Stronger together.
Yeah.
Kelly?
Well, I've just come from a meeting in Melbourne from the Public Health Association of Australia on the commercial determinants of health. And the conversations there are very different from the ones here, I have to say, because there's a real concern, a fear of transnational corporations as they are today dominating the world economy. And I'll say what I said there is that states have many different forms, markets have many different forms. The two are very integrated, and I think Parfait said this very well. You cannot have one without the other. Politics and economics are interconnected. So the question is, how do we balance those two, and how do we protect public interests from private interests that may not necessarily foster those? And there are things like conflicts of interest measures, firewalls, transparency requirements to manage that relationship. We cannot go in without having those institutional frameworks in place, because the imbalance at the moment is very skewed. But no one's talked about a well-being economy here, I think, on today, but that might have been brought up in other sessions at this conference. And there's a lot of talk about how do we create economies that are driven by human health and well-being, planetary sustainability, rather than just constant wealth creation, generation, and of course, the hoarding by very small numbers of people. How do we share those benefits? And it may be that the transnational corporations, the form of companies that we see today, are not the vehicle that we need.
Mm-hmm. Right, that's a bit depressing, thinking about how you change the form. There will be resistance. Dr. Suwit, to this question, but also another popular one has to do with political systems other than democracies and how they interact with global governance and global health governance structures.
Kalipso, did you join the session on politics?
This is the
led by Michael Reich. He will answer all these questions. Those who join that. Politics is the mechanism and process to decide who gets what, when, and how. Mechanism and process to decide who get what, when, and how. So if you want to make the right policy for just healthcare system, you need to do politics. If you hate politics, if you hate politicians, you cannot achieve anything, because politics is policy. Now you mentioned about intersectoral or multinational or intergovernmental collaboration, there are 3 words that we should understand. First, I have to tell you that English is my 3rd language. First, coordination. I just get to know you. I'm ready to share some of my information with you. This needs some level of trust. Then when you move up a bit, I'm doing some work. I cannot do it alone. I need you to cooperate with me. That's cooperation. You are the leader. They cooperate with you. That needs another level of trust. Then when you come to collaboration, it means that everyone owns that movement, like the rural doctor movement. Everyone owns that movement, not belong to anyone. Then you need the supreme form of trust. And trust goes reverse with self-interest. Whichever organization has high self-interest, they'll get the least trust from the people. So if you want to collaborate, build trust.
Kelly, you mentioned political innovation, and there's a few questions here about examples, perhaps suggestions for global health institutions on how they could innovate politically.
Yes, and there's such a movement presently around the world, which I take heart from. And there's, for example, the Innovations in Politics Institute in Europe, KESEB, K-E-S-E-B, which is an NGO, which works in Brazil, India, South Africa, and the US. And the Institute for Multi-Party Democracy in the Netherlands is just 3 examples that I encourage people to check out. They're doing very important work. I think political innovation is something relatively new, but they focus down on 3 areas. One is citizen-focused, so talking about increasing citizen participation, and it is actually very low, even in stable democracies. So we have to do things like citizen assemblies, for example, where you call together a subgroup of citizens. It might be a priority population. It might be a group that is particularly expert within the citizenry, and consulting them on particular issues that you may want to move forward. The Join Politics group in Germany are working on areas around this. How do you get citizen assemblies working functionally? Leadership focus, so I think we heard, we need good leaders. How do we foster that? How do we encourage, train, and incorporate the right public interest values into our political leaders? And then thirdly, structural changes that happen, creating those infrastructural changes and the rules of decision-making where politics, the process of who gets what, when, and how, happens in a way that is reflective of people. Governance institutions are for people. So you might want to look at #FixPolitics in Nigeria, which is working around, what are the reforms that are needed to democratic institutions that could enable more, rules that reflect people. So I don't mean to be depressing when I talk about, these issues, actually trying to encourage people to look up and think, we are not without hope. There are things happening out there in this space, and I think if global health community can jump on board, there's a lot to learn, but a lot to also share.
Thank you. So how do you decide, who decides rather, whether governance is good or bad? Somebody asks. Daniel?
Again?
Who decides if governance is good or bad?
Well, you have, it's about the health systems is about getting access to everybody when they need it, independently of how much money you have in your pocket. So governance is about how to coordinate that access and facilitate that. My perception is that we need to focus more on how effective that governance is and how the results are delivered and how we start preventing problems instead to finding solutions of problems that we knew they were about to come. So good governance is about that, I guess.
About results.
Yep.
About results. And what about CSOs? Dr. Suwit, somebody is asking about how to institutionalize CSOs in governance. How do we, I mean, you gave some fantastic examples, but how do we get there? How do we bring CSOs in as an integral part of governance? And not biased CSOs. I mean, the CSOs can be captured, right? They're not.
Well, there are three kinds of CSO, three kinds of NGO. 3B, NGO that brain. They do research. Many of you here. NGO that bark. They are watchdog. Oh, oh, oh. See something, smell something bad, they bark. Tell the people. And NGO that bite, who go to the ground. You don't have to establish them. They establish themselves. And you ask me who decide whether it's good governance or not. It's you. Not only decide, but it's you who make sure that the governance is good. Don't ask other people to give you a good governance. It's you, every one of you here, that will make the governance of your institute, of your house, of your country good. Don't ask from the God. Ask yourself.
And just building on that, I absolutely agree. There's something called the Edelman Trust Barometer, which measures trust in public institutions and in government leaders. And they did a study of 28 countries, and they found that 42% of citizens worldwide distrust their government leaders. I think that's an indication of we're not there. You know, our governance institutions are not working well. 48% consider governments a divisive force. Divisive. And that's the whole point of governance, is to bring people together for collective goals, for shared goals, and they're not doing that job according to these polls. So I think those are really worrying signs, not just for those of us who are on the, I guess, on the sharp end of that, but those leaders should be really worried that people are not buying in to their positions and their processes. It's not sustainable. It's just not sustainable.
I wonder if they are worried.
Can I add on this? There was also another poll. Which profession you trust most in your country? In Thailand, politician is the lowest. Doctors are the top. That's good. Why? Because the politician want to gain trust. They have to work with doctors. Doctors can whitewash them. And then we can negotiate with them. Because if you want your face to be less dark, you come to us, we work with you. But based on these conditions.
Right, so I've got a last question I'd like all of you to take. I'll start with you, Parfait, if that's all right. It's about accountability, and it's about holding global organizations, I guess global health organizations included, to account. Because many times somebody says they tend to do the opposite of what they demand of governments when it comes to things like equity, for instance, or debt. So how do you hold them to account? And don't say, Dr. Suwit, it's you. I don't think it's that easy.
Well, thanks so much. Holding accountable those organizations depends on the frameworks that has been set. So one cannot only hold accountable one big institution. Let that organization is called multilateral. So it depends on the policy and the rules of the game that has been set before. So I'll just give you an example of COVID response. So when we talk about the accountability, so it has to, if there's been a commitment that has been made throughout big forum or throughout negotiated table, and it has to, let's say, for example, there should be a sharing of vaccines across the, I would say, low-income countries. So that accountability should also with follow-ups. I mean, it means that not only the commitment of making that you're going to have share a very equitable distribution of vaccines, but it has to be practical. I would say a practical way to put it in action. But when it comes to accountability, each party try to take its own position. Perhaps maybe in the future there should be a way of defining some metrics for accountability, going beyond the accountability. Otherwise, the way we're seeing things, it's quite more so qualitative, not quantitative. Thanks so much.
Thank you, Tanya.
Yeah, I think the idea of accountability comes with legitimacy, right? And I linked that with your concept of trust. I think is huge. So I was saying before, it's important results, but it's also important how to reach the results. Yes, and legitimacy is about that, and accountability is the way you look at how that policy-making process was legitimate. So, yeah.
Right, yeah, indeed.
I myself joined 27 times World Health Assembly and countless times Executive Board of WHO. At least this organization I know well. You cannot hold them accountable. It's useless. Kill it and re-establish new thing. And they are doing that. That's why the rich country froze the assessed contribution since 20 plus years ago. And they put more money on voluntary contribution. And they create global fund. So many global health partnerships. Why? Because when they go to the World Health Assembly, the US has one vote. No matter how big you are. Canada, UK, France. Same as Vanuatu, a small island with about 10,000 people. Also have one vote. Do you think they are happy? No.
I hope Donald Trump's team is not listening to that.
I think Donald Trump gives a great opportunity. Be realistic. Look at the COVID-19. The WHO recommend no travel restriction. Everyone do. The WHO recommend no wearing of face mask. No one listen. The WHO say, don't switch the vaccine. If you go with the first vaccine on this, the second dose must be the same. No one listen. Do they have any credit anymore?
I think we're running out
It's
of
my
time.
organization.
Thank you, Dr. Suwit. We are running out of time. I didn't say that in the flippant.
Well, just very quickly, I think we can't have accountability without transparency. So I would say create institutional mechanisms or processes that shine light on what these institutions do. And they tend to be very remote and removed from the average person. We need to demystify how these organizations work. What do they do? What are they responsible for? How do they impact everyday lives? And until we can do that, we can't get people to care. And I think people are just tuning out or being very resentful of these institutions. We saw this during the pandemic. Yeah. WHO had a struggle because it was actually very poorly understood as an organization. And that allowed a vacuum, which then people, put in all sorts of versions of what WHO does. So it has in the organization's interest to be more transparent and to explain to people what they do. And I think that would be a good starting point.
Thank you. That's a good ending point for our panel. Thank you very much. Thank you. I'm looking for our chair to come and close the session. Thank you.
Thank you very much. And I don't know how you as an audience we feel about this session. Are we all depressed? Or are we getting energy? I hope you get energy. And then I think from my side, I think is that each of us in the audience, whether you're fixing your house, you're killing WHA, or you think about the new regional majors for having more accessible medical countermeasure in your own region, I think it's time really to take action. So thank you very much again for all our speakers and the moderators and the organizers, and have a good day. Thank you, Kelly.
Thank you, Dr.
Hey, thank you, Daniel. Yes, go ahead.
Okay, thank you so much.
Thank you.
Yeah, it's very difficult.
You like it?
Very interesting. Very interesting.
Thank you.
Fantastic. Very much.